Bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Muy buenas amigos desde Alicante, y seguimos con la sesión de optometría y con este apasionante mundo del tratamiento de la miopía por métodos basados en la evidencia y que están en completo desarrollo. Quiero agradecer a Hoya esta sponsorización de esta sesión especial. Os invito a visitar el stand de Hoya en nuestra exposición virtual y que ciertamente os va a encantar porque tiene muchísima información, y esta sesión tiene un título muy interesante porque es Confidencia a través de la evidencia, práctica diaria de las MiYOSMART. MiYOSMART, como sabéis, es un tipo de tratamiento basado en el uso de lentes que precisamente hoy ha desarrollado y que se van a presentar en esta sesión, que me honro en coordinar con Rosario Gómez de Liaño. Hola Rosario, buenas tardes. Bien, Rosario está online. Muchas gracias. Entonces vamos a tener tres ponentes muy interesantes sobre temas que creo que nos van a apasionar. Y el primero va a ser Carolina Rodríguez, que nos va a hablar sobre DINS, Technology and its Evidence for Myopia Management. Tienes la palabra.
Hello, my name is Martín Acevedo, and I am a pediatric ophthalmologist and strobologist, and I work at the Hospital Universitario.
Good day to everybody, and thanks to the organizational committee for letting us be in here once again talking about myopia management. My name is Carolina Rodríguez, and I represent Hoya Lens Iberia, a subsidiary of Hoya Vision Care, the company that introduced DIMS technology to manage myopia progression in children with a spectacle lens. As all of you might know, myopia prevalence is increasing all over the world for different factors, as for instance, the near work activity or the less time spending outdoors. WHO expects that in 25 years, half of the world population will be myope, and the increased prevalence is critical in children. Not only because the percentage of myopic children is higher than ever before, but because the onset is being earlier, and the sooner the onset is, the faster the progression, especially until the 12 years of age. If the progression is higher, the myopia will be as well. And the untreated myopia can lead to complications in the future. Not only more severe complications, but the complication will be for more people as the prevalence is increasing. Therefore, our goal is to treat myopia progression to ensure long-term eye health and to preserve vision for the future. Myopia management solutions help us with that, and that's why in recent years there are more and more solutions available in the market, which is great, but it also creates challenges to professionals to select the right solution for their patients. Evidence is key to help us understand what we should expect to each treatment option and to choose the best one for every single patient. International organizations provide us information about the different solutions available in the market based on its evidence. On the screen, you can see the International Myopia Institute infographic, but there are more available. In all of these infographics, DINS technologies appears. So let's talk about DINS technology. DINS technology is only available on spectacle lenses, which means that it is a non-invasive and safe treatment option. It's commercialized under the name of MiYOSMART, and the structure is like the illustration you can see on the screen, although, of course, this is an illustration. A real lens looks like a normal one. you cannot see all those islands or dotted that you are watching on your screen. This technology is based on the peripheral defocus theory, vastly adopted by researchers and professionals all over the world. The structure of this technology allows normal vision and myopia management simultaneously, and the wearer is able to see clearly through all the lens surface. This is how an ophthalmic lens with this technology is. But what about the evidence? What about the results of the efficacy? Different studies were carried out about DIMS technology, and the key one is the 2 years randomized clinical trial, which showed that DIMS technology slowed down 60% myopia progression on average. After this study, the third year follow-up was conducted with the same subjects, but now all of them were wearing DIMS technology. The study was published on the British Journal of Ophthalmology as the first one and confirmed the sustainable effect of managing myopia progression during 3 years and the effectiveness of this technology even if we start later than we would like. This is great news indeed, as not always we have the chance to start treating right after myopia onset. But not only that, the same subjects continue to be followed, but after 3.5 years, the researchers were forced to stop providing eyewear to participants due to COVID-19 lockdown. The wearer bought what they consider as all of them needed a prescription, transforming the 2 initial groups into 4 with different options. What at the beginning looked like a nightmare became an opportunity that provided key information to the researchers. They confirmed the sustainable effect over 6 years in those children who wore DIMS technology during that period of time. But they observed as well that stop wearing DIMS lenses showed no rebound effect as other methods of myopia management showed. This study is the only one until now in terms of ophthalmic lenses that demonstrated the lack of rebound effect after stopping the treatment and only apply, of course, to DIMS technology. We cannot assume that this is happening with another ophthalmic lenses. Maybe you may think that this is enough, but we are far away to have enough evidence, as we need more studies to cover questions that arise every single day at daily practice. For instance, if the lenses performs equally in different ethnicities, age groups, in combination with other therapies, how patients tolerate the lenses, etc. Currently, there are more than 50 publications about this technology carried out by researchers from different places in the world and covering different topics as tolerance, adaptations, comparable vision function to single vision lenses, alone or combined with atropine and different doses, and even the effectiveness in Asiatic and European children with similar, although no comparable effects. There is a publications that found out that higher wearing time in children under combined therapy when they were wearing MiYOSMART Chameleon, the photochromic option of this technology. That it's something that we should take into consideration at normally this kind of therapies are dose dependent. As I said, more than 50 publications you can find in the QR code, and there are more to come. These spectacle lenses are already available in more than 30 countries. Practitioners of 5 continents can take into practice the scientific evidence and provide clinical evidence, which is extremely important as well to know if the technology performs as expected in real life conditions. So now it is time to practitioners. It is an honor for me to let two pediatric ophthalmologists that work in different parts of Spain share their experience managing myopia management with this technology. Thank you very much for your attention.
Thank you very much, Carolina, for this outstanding introduction to the digital technology. Now, the next speaker is Dr. Martín Acevedo, that will talk about peripheral defocus spectacles as a treatment of the progressive myopia in children, my expertise and how to use them in my practice. Very interesting topic, and please follow with your presentation.
Hello, my name is Martín Acevedo, and I am a pediatric ophthalmologist and strobologist, and I work at the Hospital Universitario Puerta Hierro in Majadahonda and at the Ophthalmist Clinic in Madrid. Today, I'm going to be talking about peripheral defocus spectacles as a treatment for progressive myopia in children, my experience and how I use them in my daily practice. In the first place, I would like to thank the organizers of this meeting for inviting me to speak at it. Myopia, as we know and have talked about today earlier, is a growing problem. The prevalence of myopia is increasing worldwide, and by 2050 it is predicted that around 50% of the world population will have myopia. Myopia, and especially high myopia, is associated with multiple ophthalmological problems, such as myopic maculopathy, open-angle glaucoma, retinal detachment, and early onset cataracts. The management of myopia is especially important in children because it is at the stage when we can act and decrease the growth of myopia or even stop it. We have seen in the last few years an incidence increasing of myopia cases in children. This is because of changes in the lifestyle, especially since the 2019 global COVID pandemic. These changes include an increase of nearsight activities, especially a higher screen time usage with electronic devices. The management of myopia in children should always include a change in habits and lifestyle to include more farsighted activities, especially those outdoors and in the sunlight. On the other hand, we have a treatment of myopia for which we have three main options. The first one being orthokeratology, that I won't go into any further today. Ultra-diluted atropine, that is a very good option and could be used in association with other treatments. And peripheral defocus that we have in both presentations as contact lenses and spectacles. What is peripheral defocus and how does it work? When we have a myope patient and we correct him with a negative lens, we achieve foveal focus. By this, the patient sees correctly, but however, we induce a hyperopic peripheral retinal blur. This may induce axial length growth. On the other side, if we have a foveal defocus, it may also be a promoter of axial length growth. If we manage to combine a foveal focus with a myopic peripheral blur, we should be able to inhibit this axial growth because we don't stimulate it. We can find the treatment of peripheral defocus in two presentations, either on contact lenses or in spectacles, such as the DIMS technology. The main advantages of the peripheral defocus spectacles is that they are fairly easy to adapt. They are very easy to combine with pharmacological treatment if needed, such as atropine ultra-diluted drops, and there's virtually no age restriction for this treatment. The main disadvantages would be the price, which is higher than a regular lens. However, this is changing, especially in the last few years, because the market is adapting to the high demand. And also, another inconvenience is the need to wear the spectacles around 8 to 10 hours a day for at least 6 days every week. This sometimes may be difficult to achieve in children that don't have a very high myopia, that tend not to use their spectacles all the time, especially when at home or during the summertime. Okay, so now I'm going to talk about my experience and how to tackle a myopic debut when it happens in daily consultation. First, we must mention that every case is unique and must be approached as an individual. This is just a mental scheme on how to approach it and how I do it. First of all, we should always advise habit and lifestyle changes. As we mentioned before, the increase in outdoor activity and sunlight exposure and the decrease of nearsight activities decreases the progression of myopia. So we should advise it to every patient that experiences a myopic debut. If the child is under 9 years of age, and if the spherical equivalent under cyclopedia is under -1 diopters, I would recommend monofocal lenses for visual strain if the patient has symptoms. If not, just lifestyle changes. However, if the spherical equivalent under cyclopedia is over -1 diopters, I would recommend spectacles for everyday use and recommend the usage of peripheral defocus DIMS technology spectacles. In this picture is the youngest patient I have using peripheral defocus technology. When he started, he was 3 years old and he adapted perfectly to the spectacles. If the child is over 9 years of age, the only difference from the previous slide is that I present the peripheral defocus contact lenses as an alternative to the spectacles. However, I tend not to recommend contact lenses on a first visit, and I always recommend the patient to have spectacles as an alternative to contact lenses, even if he uses contact lenses, just in case something happens or he needs an alternative or someday he feels like not wearing the contact lenses. Okay, so now we are going to talk about how to approach myopic progression. First of all, we must say that every patient that experiences a myopic debut should be submitted to a follow-up every 6 months. If in this follow-up the spherical equivalent under cyclopedia of myopia increases over 0.5 diopters, we consider it myopic progression. If it's under 0.5 diopters, we shouldn't consider it a myopic progression. If the progression occurs in a patient that is under 6 years of age, I recommend just to adjust the correction and maintain the dim spectacles. However, if the progression occurs in a patient that is over 6 years of age, we should adjust the correction and also add a second line of treatment, such as ultradiluted atropine eye drops. The concentration of the eye drops, if it's a patient that is beginning this treatment, should be either 0.01% or 0.02%. This concentration of the atropine can be increased if the progression is maintained in further follow-ups. In conclusion, we can say that myopia's prevalence is increasing, and preventing the progress of myopia in children may decrease the complications derived from high myopia in adults. Considering this, it can be said that not treating the myopic progression in children would be extremely unwise. Peripheral defocus and dim spectacles are a great tool to mitigate myopic progression, either as single therapy or combined with other therapies. Here is the bibliography I used to make this presentation. Thank you so much for your attention. Here's my email. If you have any questions regarding this presentation, you can write to me. Thank you very much.
Thank you very much, Dr. Martin Acevedo. Excellent introduction with real clinical data. And what is the plan to follow in different cases with myopia progression in children? Now, Odalis Aramburu will talk about her experience with different ophthalmic lenses for myopia management. Odalis, you are the next.
Hi, I am Odalis Aramburu. I am from Venezuela, but living in Catalonia, Manresa, since 2017. I have no conflicts of interest in this presentation. My experience with myopia prevention and control began almost 15 years ago with atropine 0.01% topical. But my experience with ophthalmic lens begins with a peer group in 2019, 2020, 22. 369 myopic or premiopic patients under 18 years old. 44.9% under 11 years and 55.01% between 11 and 17 years old. After 4 years in the first group, only 32.8% continued to manage myopia progression. 46% glasses myopia control, 28% topical atropine, 12% glasses myopia plus atropine, 21 myopia contact lens. In our hospital, myopia management include: number 1, lifestyle change with screen time control and increased outdoor time to all patients. 2, glasses with peripheral hyperopic defocus control. 3, topical atropine. What type of lenses? These: number 1, the focus incorporate multiple segment. 2, halt eyelid spherical lens LED target technology. 3, clear focus. 4, horizontal asymmetric peripheral defocus. 5, contact lens adopt extended focus, peripheral dual focus. But what kinds of management do we recommend? I recommend it varies depending on patient age. Under 6 years old, I prefer atropine. Economic resources, because this kind of lens are expensive. And type daily activity, because like sport, like music training, dance, gymnastics. With the patient, I prefer contact lens or combined contact lens with ophthalmic lens, but it's expensive. But for me, the ideal treatment actually is ophthalmic lens. Number 1, avoid prolonged topical treatment with secondary effect. Number 2, theoretically less rebound effect. 3, treatment does not depend on non-commercially available medication. The problem with this promising technology, high cost, glasses decentering, is associated with alteration of visual acuity, very frequent, common in children, contrast sensitivity alteration in low lighting, especially for older patients. After 6 years with this kind of patient, the DIS technology and HAL technology achieved control of spherical equivalent progression in around 80% patients and control axial progression in 70-80%. There are around 20% patients that require additional therapy like atropine to achieve control progression. Clear focus technology, we don't have enough follow-up time. The important is remember that the principle is control the myopic progression and avoid axial length greater than 26 millimeter and spherical equivalent greater than 5 dioptrics. Because the low vision and blindness is related with axial length and spherical equivalent. Thank you very much for the invitation.
Thank you very much indeed, Odalis. And now we have an open debate. I would like to invite Rosario Gómez de Leaño to be on the stage to preside in this space, virtual space, this debate. And we have a new invited guest for the debate, who is Empar Sant Marcos from Castellón. I think that is a very interesting topic. And Rosario, what do you think about this doses? Combined treatments, optical treatments in general? Would you choose to have a stepwise approach or to indicate for everybody the same? Tell me your approach and let's open the debate with this question.
Well, again, congratulations to all the speakers to be so clear with your talks and so constructive. My point of view is that we have different factors when we have a patient. It's not only the myopia that it is increasing. So anytime that comes a patient, I see how old is he? Which are the parents? Does he has one or two progenitors that they are myopic, small, medium, or large? And which is the axial length proportional to his age, sex, and ethnicity? With that, we have a number. Let's say a child with one parent myopic, with very small hyperopia, but already with a larger eye for his age, then I will be very aggressive. I will begin with both drops and lenses. Of course, it is an economical debate, but I always say we give so many intravitreal injections, so our children merit the same. We have to help them in order that that be resolved. But for the moment, if a child is small and has a large eye, he should be addressed as aggressive as we can. And not aggressive in terms of being too aggressive, but we have to treat them with drops and with glasses, with peripheral defocus, because that is the best for a child age 6. Then, if the same situation that you have it with an older age, then you may debate, because it's not such a severe case, and you can combine. Of course, if you have a child with 15, and he's asking for contact lenses, we have to promote treatment with contact lenses and drops. But it is a matter of how big is the eye, which is the age, what's the prognosis, and finally, which is the quality of life they are doing. Because as I heard today, we have to promote to have a healthy life. But for instance, one thing we have seen in our study is that the big difference between children that progress and don't progress is what they do on the weekends. In Madrid, every child does the same during the week. So we have to promote to change the habits for the weekends.
Okay, and in part, you are now in this debate. Which approach do you have, and especially about this interesting technology, MiYOSMART? Which is your experience? How do you use MiYOSMART in your patients?
Well, I would say I don't have big conflict of interest outside the passion of the investigation that we are doing. Then when you have good results, you are passionate with it. So that is my conflict of interest. It is that we had very good results when we combine treatment. I mean, the percentage of children that maintain the axial length with the combined treatment was much superior to the ones that only had drops. So In my opinion, if we can, and the economics allowed for it, if we have a case that is going to progress, I will promote the combined treatment because it was much more efficient than the simple treatment.
Okay, Empar Sanz, can you hear me, Empar? Yes? From Castellón, you don't? Empar, my question to you now is, how do you use these lenses in your practice? So let's open the panel. Okay, no problem. So what about Martin? Because you have make a very nice, let's say, display about how to use the different technologies. About the MiYOSMART, how frequently you use it in the context of the other treatments, and whether you use it more combined with low or very low dose atropine or alone?
Well, as I said in the presentation, I usually, when the child is over 6 years of age and and he is progressing, the myopia is progressing, usually I do the combined therapy, the lenses, the MiYOSMART lenses, and the diluted atropine drops. If he is under 6 years of age, it depends a lot on the child. If I see that the parents are willing and it's a child that is well behaved when using the drops, then I recommend it as well. I am aggressive. If I see that the parents are a bit reticent to use the drops in combination with the spectacles, I tend to maintain the spectacles until 6 years of age. And for the children, I do the combined.
Good. And Odalis, this question is for you. Which disadvantages, let's talk about disadvantages that you see in MiYOSMART technology in general the treatment of children that are with evolutive myopia. Do you see any disadvantage, for instance, intolerance, cost efficiency, something that you can really tell at this regard? Thank you. Okay, Odalis, have you hear me? Okay. Since connectivity with Odalis is not good.
Hola,
so,
¿me oye?
Okay.
¿Me oye?
Sí, yes, muy bien.
Okay, my experience, I prefer speaking in Spanish. I know. Hola, ¿me oye? ¿Me oye? Sí.
Yes, muy bien.
Okay. My experience, I prefer speaking in Spanish. I know. Hola, ¿me oye? Sí.
Yes, muy bien.
Okay. I prefer repeating. Okay, mejor.
I think communication with Odalis is very, very
Mi
poor.
experiencia es grande porque yo comencé en 2012 con atropina en Venezuela y me iba bien porque era lo que teníamos. Aquí actualmente desde el 19 comenzamos con atropina, que era con la época de la pandemia, pero pronto tuvimos las lentes oftálmicas y se comenzó el uso de lentes oftálmicas. Y nosotros no recomendamos una en particular porque no los prohíbe. La institución dice el padre debe escoger. Yo les doy las opciones. Todas las opciones que yo nombré allí son las que yo estoy usando y todas las he utilizado. ¿Y cuál es mi experiencia? Que las que funcionan son las dos primeras, el múltiple segment y el altamente esférico, ¿no? El HALT. Porque las otras, el control es muy pobre. En los pacientes, como dice la doctora, que tienen antecedentes familiares, ambos padres miopes, miopías magnas de alguno de los padres, o que comienza muy temprano la miopía, sí somos agresivos. Yo hago terapias combinadas y estoy combinando atropina con lentes oftálmicas. Pero yo tengo un problema. En mi zona hay una alta incidencia de miopía en inmigrantes del sur, digamos de Marruecos, que son de muy pocos escasos recursos económicos. Ellos no son capaces de comprar una lente oftálmica especial. Entonces, aquí en la zona se ofrecen unas lentes oftálmicas de defocus periférico, que es como el bifocal horizontal, digámoslo así, pero la experiencia es mala, no funciona. Entonces, ¿qué hacemos en esos casos? Combinamos con las gotas. Mi experiencia particular es que realmente, ¿qué nos ha funcionado a nosotros? Estas lentes oftálmicas modernas, múltiples segmentos de focus, y las altamente esféricas. Las lentillas de contacto, porque tenemos pacientes que hacemos combinaciones de lentes de los dos tipos, también están funcionando. Y en quienes no logramos es en los que adicionamos, que llevando estas lentes adicionamos la atropina. Pero hemos observado que, y esto me parece una pregunta para ustedes, yo tengo pacientes que yo logro control del equivalente esférico, pero la longitud axial inicialmente yo no la logro controlar. O otro ejemplo es que tenemos pacientes que un ojo está controlado completamente, el equivalente esférico y la longitud axial, la progresión dentro del límite de acuerdo a la edad. Pero resulta que el segundo ojo, el otro ojo, no está controlado. ¿Qué es lo que ustedes sugieren en estos casos? ¿Qué harían ustedes en estos casos? Que teniendo incluso una terapia combinada, un ojo no sigue progresando.
A mí me pasó con una niña y yo le pregunté si siempre empezaban a echarle la gota por el mismo ojo. Y entonces les dije que cada día echaran en un...
Alternada.
Sí. Y yo pregunté si siempre empezaban a echarle la gota. Sigue progresando un poco, ha bajado el ritmo de progresión, pero sí, en mi experiencia también, la longitud axial casi siempre... O sea, esto frena un poco, pero la longitud axial sigue. El ritmo de progresión, pero sí, en mi experiencia también, la longitud axial casi siempre... O sea, esto frena un poco, pero la longitud axial sigue.
Y entonces a la larga, si no frenamos realmente la longitud axial en un valor adecuado a la edad, es decir, no estamos frenando. Y otra cosa es, ¿hasta cuándo van a utilizar, es decir, este tipo de tratamiento? Es decir, ¿cuánto estaría? Y es una de las razones por las que yo considero las lentes oftálmicas son el recurso más importante, porque un paciente al que le tengan que colocar una gota todas las noches, 10 años, que si yo empiezo a los 6 años y debo llegar a los 15 más o menos, son 10 años utilizando una gota. Que la otra gran desventaja, y eso está descrito, que los trabajos que dicen atropina no funcionan muchas veces porque son preparados fórmulas magistrales en nuestros medios y por lo tanto nosotros no sabemos ni el vehículo y el vehículo afecta la duración, la estabilidad y duración del medicamento y ni siquiera estamos seguros de la concentración de que nosotros estamos utilizando. Entonces,
me gustaría, porque estamos tratando muchos temas y se dejan flecos, habéis hablado de si aumenta la biometría o no y qué significa, qué pasa con las formas unilaterales, qué pasa con la complianza, y yo creo que son temas, todos ellos muy puntuales, que creo que deberíamos de zanjar. Una primera cosa, si me permites, Jorge, que lo modere así, es que yo creo que todos debemos hablar de biometría. Y cuando digamos si el ojo, si la miopía se controla o no se controla, tener un dato biométrico, porque yo creo que es el parámetro que debemos de utilizar, porque en el fondo lo que no queremos tener es ojos grandes, no con una refracción determinada, porque esa la podemos operar. Lo que no queremos tener es ojos grandes que tengan factores de riesgo. Esa sería la primera cosa. Es verdad que hay ojos que siguen creciendo, pero en el ser humano también. Es decir, al niño de los 9 a los 15 años el ojo le sigue creciendo. Lo importante es que crezca lo menos posible en número de milímetros. Es verdad que hay pacientes que les crece la miopía más un ojo que en otro, pero para eso son los estudios grandes. Todos tenemos pacientes que un año le ha crecido el ojo derecho y el año siguiente ha sido el izquierdo. Y eso cualquier persona que haya tratado miopía y pacientes lo ha visto. Un año creció el derecho, otro año. Pero sí que es verdad que hay ojos que son anisométropes y que siguen siendo anisométropes y lo será más. Nosotros tenemos un pequeño estudio de anisométropes en los que los tratamos un solo ojo. Efectivamente, es decir, que yo creo que hay mucha patología dentro de la miopía para gestionar. Pero a mí me interesa, y si me permites, Jorge, porque me habías puesto de moderadora, preguntarle a Carolina, porque creo que si hay una lente que está posicionada un poquito por encima de las demás, un poco yo creo que por la seriedad de la investigación, son las lentes DIMS. Y me encanta ver que 5 años, porque nadie tenemos esos estudios, y estos estudios son desde fuera sobre todo, y espero que algún día los podamos tener, pues que a los 5 años estas lentes siguen siendo positivas. Cuando con la atropina decimos que a veces que al cabo de los 2 o 3 años igual ya no es igual de eficaz. Y que hay 50 publicaciones, que me parece como ya para dar información, y sobre todo que no hay efecto rebote, que es lo que yo creo que ha sido interesante de estos estudios. Entonces, mi pregunta, Carolina, creo que tenéis unas lentes fotocromáticas. ¿Nos podrías hablar de ello? Porque creo que hay una cosa que es interesante de ello. Carolina, ¿me oyes? Pues no sé si llega la información.
No lo sabemos, pero sí te quería preguntar, Rosario, el perfil del paciente de éxito, ¿lo puedes definir? Porque hay casos que van bien, otros, un 30%, que no hacen el efecto debido, de acuerdo con información que acabamos ahora de oír también de Martín. ¿Cuál es el perfil ideal que indica que el tratamiento va a funcionar? Esta pregunta la hago extensiva a todo el grupo de debate. Gracias.
Vamos a ver, yo creo que hay dos cosas. Por un lado, el niño de por debajo de los 6 años, que ya es bastante miope, y yo creo que ese es otro grupo dentro de los miopes en los que ni hay estudios y probablemente sean unas miopías congénitas de un perfil distinto, y creo que no todo debe de estar dentro de la misma bolsa. Yo creo que tenemos que hablar de lo que sabemos, que es del niño entre 6 y 12 años y entre 12 y 18 años. Y son dos perfiles muy distintos, porque su genética suele ser distinta, sus hábitos suelen ser distintos y su progresión suele ser distinta. De tal manera que si tenemos un niño, para mí, ideal porque me va a funcionar, cuanto más tarde mejor, pero ideal porque es donde más impacto va a tener nuestros tratamientos, es un niño de 6, 8 años, que ya veamos que tiene un ojo con poca miopía o casi hemétrope, porque dentro de las cosas que tenemos que decir es que también estamos intentando prevenir ya que se empiecen a hacer miopes, porque cuanto más tarde se empiecen a hacer miopes, menos va a progresar. Entonces, para mí, yo creo que el niño ideal, si tuviéramos que hacer una campaña de detección, es, por favor, ¿podemos intentar hacer biometrías a todos los niños de 6 años para que podamos definir cuál es el de poco riesgo, medio riesgo, alto riesgo, y podemos crear unos pronósticos para que podamos actuar en de la manera más adecuada posible, donde de verdad la miopía va a progresar más y donde más impacto vamos a poder tener?
La genética juega un papel evidente. ¿Harías una distinción entre los niños con una genética altamente predisponente a la miopía, véase ambos progenitores miopes, de aquellos que no lo son tanto?
Sí, del peral salen peras y eso es una realidad. Lo que pasa es que a veces no es la madre y el padre. La madre igual no es miope, pero todos los hermanos de la madre son miopes y igualmente. Entonces yo creo que hay que hacer un poco, yo directamente ya pongo antecedentes familiares. Madre -2, padre -7. Y pongo en mi anamnesis de una manera muy grave. Muchos más, pero muchos tíos miopes. Y entonces ahí le damos como un puntaje, y esto hay muchas tablas que uno las puede meter. Entonces, si los padres son miopes leves, moderados o severos, se les da un punto más, y si es 1 o 2, se les da un punto más. La biometría de partida.
Bueno, pues yo creo que sí. Muchas gracias. Bueno, ya nos toca ir terminando. Yo quiero dar las gracias de verdad a todos porque ha sido un debate súper interesante. Carolina, gracias por abrir esta sesión con la tecnología DIMS. A Martín por ofrecernos tu perspectiva, indicaciones y entorno de indicación de estas lentes junto con el tratamiento tópico. Y a Odalis por la experiencia que tienes histórica, tanto con las gotas de atropina, las diluciones como con las gafas. Y esta tecnología, evidentemente, efectivamente MiYOSMART es una tecnología actual y de futuro, tecnología que está, como ya hemos visto en las últimas palabras de Rosario, pues buscando una indicación de un grupo de éxito máximo, y ciertamente que es coste eficaz, puesto que estos niños, a la medida que vayan creciendo, si son menos miopes, van a evitar muchos problemas, y ciertamente que es una gran aportación clínica. Yo quiero agradecer a todos, a Hoya en particular, por vuestra participación de esta sesión especial. Visitar, por favor, en la exposición tecnológica científica el stand de Hoya, os va a gustar, y ciertamente que creo que tenemos un tema para ahora y para el futuro. Así que muchas gracias a todos y vamos a cerrar la sesión. Gracias de verdad.